All right, everybody. Good afternoon. Welcome to this week's Engel Round presentation. It's nice to see people here from psychiatry, neuroscience, and psychology. Today, our presenter is Judy Thompson, who is an assistant professor in the Department of Psychiatry. Judy is a schizophrenia researcher. She got her degree from the University of Pittsburgh, did a fellowship at Columbia University, and was faculty member at Rutgers University before coming here. And she'll be talking today about natural speech processing, the influence of prior knowledge, and auditory hallucinations in schizophrenia. But before she does, just want to remind people, if you're watching on Zoom, if you have questions or comments for the end, put them in the Q&A box, or use that function, not the comments. And that's reserved for the panelists and the interpreters. And also remember to fill out the evaluation. You'll see a QR code come up at the end on the screen, or you can go to the Grand Rounds page on the department's website. Okay, so without any further delay, welcome Judy Thompson.
Thank you, Steve, and thank you all for attending today, and also for the opportunity to discuss some of the work that I and my team have been conducting for the last few years. I also want to say that a lot of what I'll be discussing today has been conducted in close collaboration with my colleague Edmund Lawler and his team in the departments of neuroscience and biomedical engineering. This is a work in progress. We are actively collecting data for this project and working to optimize our methods to address this problem. Auditory hallucinations are commonly experienced in psychotic disorders like schizophrenia. Approximately 60 to 80% of individuals with schizophrenia will experience auditory hallucinations, most commonly in the form of voices, at some point in the course of their illness. These voices are typically experienced as uncontrollable and intrusive, and often as coming from an external force or entity. Thus, they are, in psychotic disorders, they're associated with significant distress and disability. The great news is we have effective treatments for these symptoms. Many individuals experience significant relief from these types of symptoms from antipsychotic medication. And indeed, for some, these medications are literally life-saving. Unfortunately, though, a substantial proportion of individuals don't respond to these treatments. They continue to experience persistent auditory hallucinations despite being on antipsychotic medications, and an even larger percentage only experience partial relief from these treatments. Okay, sorry, it's a little delayed here. Also, these treatments are associated with significant adverse side effects. And for some individuals, these side effects are intolerable, such that they discontinue treatment because of them. Also, we don't yet know enough about the underlying mechanisms of these symptoms to identify potential subgroups of individuals who might differ with regard to underlying pathology. If we had that information, this would allow us to tailor interventions. But we're not there yet. And as a result, treatment is typically approached through a trial and error process as the clinician works to find a treatment that works for a given individual. And as a result, some individuals begin assuming that they don't do anything anyway. In fact, we've had many of our own subjects describe their experiences with treatment this way. So our overall goal with this line of work is to help clarify the pathophysiology of auditory hallucinations in psychotic disorders with the aim of informing the development of targeted mechanism-based therapeutic interventions. So what about these mechanisms? Psychosis researchers have increasingly looked to models of brain function that emphasize the role of expectations in determining perception. We now know that the eyes aren't like cameras and our ears aren't like microphones transmitting sensory information with true fidelity into our brain. That's not how we experience the outside world. Rather, our perception results from an active inferential process in which the brain integrates bottom-up sensory signals and top-down predictions regarding the likely causes of the sensory information coming in. Yes, I just said this. So basically, there is noisy sensory information coming in, and our brain integrates the sensory signals with these top-down predictions regarding the likely causes of sensory information. These processes are largely unconscious, and they're actually really powerful. So I thought I would give you a demonstration of the effect of these kinds of, the effect of prior experience or prior knowledge on how we perceive sensory information. Did anyone detect any words in that sound? Please read this sentence. I'm going to play you the same audio clip. Did any of you perceive words that second time? Okay. That's an example of the powerful influence of these expectations, these unconscious expectations or predictions that our brain is making based on prior experience in determining what we perceive. It's been shown that in the case of excessively noisy sensory input or ambiguous input, our expectations have an even stronger weighting on what we perceive. So there's a bias towards expectations when sensory signals are ambiguous. Based on this, it's been proposed that hallucinations might reflect an extreme form of this perceptual bias, such that there's an overweighting of expectations based on prior experience relative to incoming signals, to the point where individuals experience a percept in the absence of corresponding sensory input. There are now a number of research studies that have supported the link between an overweighting of expectations during perception and auditory hallucinations. This study is especially notable. It was conducted by Guillermo Jorge's group at Columbia University. They combined PET imaging with a behavioral task. What's notable is that they examined the association between dopamine release in the striatum and an overweighting of expectations during perception. Now, of course, when you think about mechanisms of psychotic symptoms like hallucinations, dopamine definitely comes to mind. We know that all or almost all of our antipsychotic medications act on dopamine. And it's been shown through a number of pivotal PET imaging studies that individuals with psychosis, even those who have never been on antipsychotic medication, have elevated striatal dopamine function. And what Guillermo's team did was to link this elevated striatal dopamine function both to auditory hallucinations and this increase in, or this perceptual bias towards expectations. We also know that schizophrenia is characterized by perceptual processing impairments in a number of modalities, including the auditory modality. So it's been posited that maybe the auditory processing impairments that characterize schizophrenia may contribute to this overweighting of prior information or expectations. So is it possible that for a subset of individuals, perceptual processing impairments are increasing the risk of developing hallucinations? Specifically, It's thought that lower level disturbances in sensory processing may result in noisy or attenuated neural representations of auditory sensations and an ambiguation of sensory input to higher language regions. And that may lead to a compensatory increase in top-down signaling during auditory perceptual processing, including when individuals are processing potential speech stimuli. So the aims of our project have been to investigate these potential mechanisms of auditory hallucinations by leveraging recent advances in the use of EEG to index hierarchical processing of natural speech. Specifically, we are evaluating whether auditory hallucinations in schizophrenia are associated with impairments in auditory processing of narrative speech stimuli and alterations in the effects of prior knowledge regarding speech content on the auditory processing of speech. And I want to throw in the second aim, which has developed for me over the last few years. As I've become immersed in the auditory hallucination research world and also worked with our subjects over the last several years and heard about these experiences firsthand, I have become more aware of the importance of us understanding the phenomenology of these experiences. Individuals often describe perceptual experiences when they hear voices, but also other associated experiences, such as passivity phenomena, for example. This could be a barrier to us really making progress on identifying mechanisms. Our standard assessments, the SCID, BPRS, PANS, don't touch on these aspects of hallucinations. And I'm hoping to talk a little bit more about this near the end of the talk today. But first, I want to spend a minute talking about our EEG methods. This will be brief and pretty cursory because of time constraints, but I'm definitely happy to address questions at the end of the talk or at any other point. It's now clear through a number of EEG and MEG studies that cortical activity tracks the dynamics of continuous natural speech. This is known as cortical tracking of speech. So basically, we can use tools like EEG or MEG and characterize how the brain is responding to speech stimuli. And it turns out that cortical activity tracks the amplitude of the speech signal as it changes over time. This is known as a speech envelope. And many studies have now demonstrated this tight association between the speech envelope and how the brain is responding to speech as it unfolds over time. This is really important in terms of this envelope tracking, because we know that cortical tracking of the speech envelope is critical for speech understanding. But one limitation is that it's really about the acoustics of the speech signal and how the brain is responding to those acoustics. So it's not so clear how this measure informs our understanding of speech-specific processing. So teams like Ed Lawler and others have established methods to examine the association between individual speech features and how the brain is responding. So that cortical tracking to features that are more about how the speech sounds. So the amplitude, which we experience as like the volume, frequency changes over time, which we experience as pitch, but also more speech-specific processes that are independent of those like lower level fluctuations. And we're using these methods for the current study to characterize speech processing in individuals with schizophrenia. The prediction accuracy value is basically an index of how well the cortex is tracking individual speech features over time. This measure is calculated for each individual subject, and we can use it as a dependent variable to examine potential group differences and also associations with symptoms like auditory hallucinations. Our method specifically with regard to characterizing speech processing, we're using two tasks that I'm going to tell you about today. The first is a clean speech task. Subjects listen to 30 one-minute audio clips from an audiobook. We're using Old Man and the Sea. Each segment of the audio continues from the next to form a continuous narrative the subject is hearing across the 45 minutes or so. And after each 1-minute audio clip, subjects are asked 2 comprehension questions about the content of the audiobook to assess engagement and also understanding of that content. As I noted, we're using what are known as temporal response functions, so those models that tell us about how the EEG is tracking specific speech features over time to characterize how the brains of our subjects are responding to this audiobook. We're focusing on 2 specific measures, specifically the acoustic spectrogram of speech and a categorical labeling of the phonetic features in the speech. We're using those model accuracy values I told you about to index the encoding of acoustic and phonetic speech features. And an important aspect of these measures is that we use partial correlation methods to basically assess how well the cortical activity is tracking acoustic features specifically, so the spectrogram, which includes things like amplitude and frequency changes over time, but also those phonetic features when controlling for the acoustic features. The second task we're using is a perceptual pop-out task. Perceptual pop-out tasks have really become popular in recent years as a way to examine predictive speech perception. How it typically works is basically what I had you do earlier today, which is listen to a degraded audio clip. Then the subject is exposed to either the clean audio or text, as I did earlier, and then the degraded audio clip again. As you may have experienced a few minutes ago, that results in a powerful perceptual pop-out where you're able to actually understand words even though the clip is identical, same level of degradation, exactly same sensory input. The only difference is that you're exposed to information about the content of that speech. We're using a modified version of this task. We developed it specifically for this study, especially with the concern that the cognitive processing impairments associated with schizophrenia may impede our ability to really get at how the brain is responding to this prior information using these speech processing measures. So we're basically using clips that are quite short, only 2 to 3 seconds in duration. So short sentences and short audio clips to really try to minimize demands on functions like working memory. The paradigm is as follows. Subjects are presented with a sentence on the computer screen, just like this, and they're asked to read that sentence. They're then presented with a degraded audio clip. Then they're asked to rate whether they detected and understood any words in the audio clip. Importantly, the text that subjects read matches the content of the degraded speech clip on 50% of the trials. Yeah. Subjects typically complete about 240 to 300 of these trials. Now, what are we using specifically to get at top-down effects? The increase, that perceptual pop-out that I demonstrated earlier, that is reflected in typically an increase in those speech intelligibility ratings. When subjects are asked, did you detect and understand any words in that audio clip? We're using the increase in speech intelligibility as well as the changes in those EEG measures of acoustic and phonetic feature encoding as behavioral and neural indices of the effects of prior knowledge. I want to tell you a little bit about our sample. This will be quick, so I can address any questions for sure after the talk. All subjects are between the ages of 18 and 55. All subjects are also assessed with the SCID. It's a diagnostic interview, and we use this to confirm that subjects indeed meet diagnostic criteria for schizophrenia or schizoaffective disorder, or for our control subjects that they don't have a history of mood or psychotic disorders. Subjects don't have any substance use disorder in the past 6 months as assessed with the SCID. We use the RAT5 to assess verbal IQ. We require that subjects have at least a 70 or higher with this verbal IQ measure. Importantly, we're recruiting 2 subgroups of individuals with schizophrenia. Our AH+ group have reported experiencing auditory hallucinations in the form of a voice at least once a week for the past 3 months at minimum. Our auditory hallucination negative group, our AH- group, haven't experienced any auditory hallucinations in the past 3 months. In terms of our controls, as I noted, no history of psychotic or mood disorders and no first-degree relatives with psychosis. Here is our descriptive statistics for demographics and some clinical information on our sample. We currently have recruited and worked with about 20 individuals with auditory hallucinations, our AH+ group, 17 individuals in our AH- group, and 33 controls. These groups are well matched. There are no significant differences on age, gender, race, or parental education. As expected, participants with schizophrenia and both subgroups have significantly lower years of education. That's not surprising. We know that schizophrenia unfortunately affects educational attainment. Our schizophrenia subjects also have lower verbal IQ as expected. What about our symptoms? As expected, our AH+ group had significantly more severe positive symptoms. These symptoms are measured with the Brief Psychiatric Rating Scale, or BPRS. This is a semi-structured interview that involves the research staff member interviewing and rating current symptoms, usually in the past week. That's what we're using. They're rated on a 1 to 7 scale. Positive symptoms include things like delusions and hallucinations. So because of how we're defining our groups, it's not surprising that our AH+ participants had more severe positive symptoms compared to AH-. There were no significant differences on negative or disorganized symptoms. However, the AH+ group had more severe or higher total symptoms. And I will say that I was surprised that the group differences persisted when I controlled for auditory hallucinations. That is, our AH+ participants still had more severe positive symptoms. They also had more severe affective symptoms, symptoms like anxiety and depression, and higher total scores, even when omitting auditory hallucinations or hallucinations in the rating. So that's something to keep in mind. Our aim was to match on those groups, but we haven't quite done that yet. Okay, what about our results? I first want to tell you about that first aim we had, which is to assess whether auditory hallucinations are associated with impairments in auditory encoding of narrative speech stimuli. First, what about those comprehension scores? Not surprisingly, individuals with schizophrenia, and actually in both subgroups, had significantly worse comprehension scores compared to healthy controls. The AH+ and AH- groups did not differ, however. And in our total sample and in each group individually, as expected, EEG was significantly related to those speech features we're focusing on, the spectrotemporal features and also phonetic features of the speech stimuli, which is really good news because that's telling us that we're in pretty good shape to use these as indices of speech processing. What about group differences on these measures? The first is the spectrogram. As you can see, and as statistics indicated, the AH+ participants had significantly weaker acoustic encoding of speech stimuli compared to both the AH- and healthy control groups. And the effect sizes of these differences were medium to large. What about, AH- and the healthy control groups did not differ significantly. What about phonetic features? There were trend level results suggesting weaker phonetic feature encoding of speech stimuli in schizophrenia compared to controls overall. It was a trend level finding. It was a relatively small to medium effect there. There were no subgroup differences, however. What about that second task, the perceptual pop-out task? So what I just talked about was that early auditory encoding of speech stimuli. Secondly, we looked at the effects of prior knowledge on speech perception. The results I'm going to talk about here are the behavioral results. Our EEG analyses for the perceptual pop-out task are still underway. So this is the behavioral results. So those ratings that we collected during this paradigm. This bar graph shows the mean intelligibility ratings for each group across the two conditions. Remember that the matching condition involves subjects reading a sentence that matches the content of the degraded speech clip that they hear. And we expect them to experience that perceptual pop-out, where mismatch trials are those where the content of the sentence they read did not match the audio clip. And as you can see, all three groups experienced a significant perceptual pop-out as expected. Now, you might recall that our what we were really interested in was the difference, that perceptual pop-out, and whether that difference, which we are using as an index of top-down effects, whether that was significantly associated with auditory hallucinations. And you might be able to tell already that the AH plus group did not have a stronger pop-out effect. And in fact, they had the smallest perceptual pop-out effect according to those ratings. The schizophrenia subjects as a group had lower mismatch difference scores, so that our index of top-down effects, the perceptual pop-out. The AH plus group really drove that difference. There was a significant difference between AH plus and controls on the perceptual pop-out, and that is a large effect. The AH plus and AH minus groups did not differ, and the AH minus groups did not differ from controls. Well, we didn't find group differences, but what about associations with symptoms? We examined BPRS results. We didn't find any associations with positive symptom severity in the schizophrenia or subgroups for the total positive symptom score or for individual items assessing hallucinations and delusions. All of those associations were non-significant. Now, we also are using another measure of hallucinations. This is a measure of hallucination proneness or hallucinatory experiences. It's called the Multimodal Unusual Sensory Experiences Questionnaire, or MUSAC. It assesses hallucinatory experiences in a variety, pretty much all the sensory modalities. It's a lifetime measure, so it asks about lifetime hallucinatory experiences, including distortions, but also illusions and full-blown hallucinations. And we did find a trend level association between stronger perceptual pop-out and the total scores on this MUSAC measure that we're using. But as you can see here, the results, so AH minus are in blue. It was only significant, or at trend level, I should say, still pretty good magnitude association at 0.52, but that was at trend level with only 12 subjects. That was only present in our AH minus group, not in our AH plus group. What about hallucinations specifically? Oh, yeah, sorry about that. I already discussed that. So another measure that we were really interested in exploring were the ratings on the mismatch condition. That is, subjects reporting that they're perceiving words when they're not provided with prior information about the content of the speech. I played that for you earlier, that we're using a pretty high level of degradation, but subjects vary quite a bit in terms of how much they're reporting hearing words in the mismatch condition. We were especially interested in this because there are findings in the literature suggesting that non-clinical voice hearers and young people at clinical high risk for psychosis tend to report perceiving speech when presented with this kind of ambiguous auditory input. And this increase in reporting words in these kinds of stimuli are associated with hallucination severity in these groups. So we did note that although it's not significant, you can see that our AH plus group tended to report that they detected more words in the mismatch condition compared to the other groups, most notably compared to controls. So we examined associations with our hallucination measures and other clinical measures with this mean ratings in the mismatch condition. First, we looked at the hallucinations item from that scale I told you about, the brief psychiatric rating scale. We found a moderate association in our AH plus group between hallucination severity as rated by staff and the ratings on the mismatch conditions. You can see, though, this isn't like such an impressive scatter plot. Everyone's pretty much clustered together at the rating of 5. And that really is a product of how we're defining our group, our AH plus group. We're requiring that individuals are having these persistent regular hallucinations. So it makes sense that they would all be clustered. There's actually a 1, 2, 3, not even shown here. But all of our AH plus subjects are clustered here at the end. So it's really hard to know what to make of this particular association. However, as I mentioned, we also have that other measure, the hallucinatory experiences measure. When we examined associations between higher mismatch ratings and the hallucination proneness in the auditory modality specifically for our AH plus subjects, we observed a strong correlation. That is, higher ratings on the mismatch condition are going with more self-reported auditory hallucinatory experiences. And this isn't restricted to the auditory modality. As I noted, this MUSAC assesses hallucinatory experiences in pretty much all the sensory modalities. And we also observed, it's trend level, but quite strong, an association between mean mismatch intelligibility ratings and self-reported hallucinatory experiences in the visual modality. What about that visual modality? Another measure that we are using is called the Mooney Faces task. This is a visual perception task. It's been used quite a bit in schizophrenia research. Some studies have documented impairments in individuals with schizophrenia using the Mooney Faces task. So basically, this involves presenting these ambiguous two-tone images of faces to subjects. They're presented upright and also inverted. And it's been shown that individuals with schizophrenia tend to report fewer faces than healthy controls. And this has often been shown in individuals with high levels of disorganized symptoms and also inpatient. So people with schizophrenia who are quite severely affected. We were interested in this measure for another reason, though. It's been shown in clinical high-risk research that there seems to be a tendency to report more faces among young people at clinical high risk. So we wondered about the effect of kind of these stable priors for meaningful information such as speech or faces in our study examining auditory hallucinations. So we're using this measure and we examined associations with mismatch ratings. And we did find significant associations between number of faces reported on the Mooney Faces task. In the upright condition, there were also similar associations in the inverted condition and mean mismatch ratings. And this was significant in the AH plus group. This was significant in the AH minus group, not the AH plus group, and significant in the schizophrenia group as a whole. The final set of findings I want to talk about from this perceptual pop-out task relate to cognitive performance. So you'll recall that we designed our perceptual pop-out task with the cognitive impairments in schizophrenia in mind. We really tried to design it to minimize working memory and other cognitive demands because of the impairments in those functions associated with schizophrenia. So we are assessing cognition in a variety of domains using the matrix consensus battery of cognitive functions. We're specifically examining verbal working memory, verbal learning and memory, and processing speed with these MCCB tasks. And we were keen to examine associations between cognitive functioning and performance on our perceptual pop-out task. It turns out that there were some associations. So I've been focusing for the last few minutes on that, the ratings in the mismatch condition. But remember that the index of top-down effects we have been especially interested in is the difference score, that perceptual pop-out, right? So the difference between match and mismatch ratings. And we're finding that lower verbal working memory scores, so worse working memory, is significantly associated with smaller match-mismatch difference scores. And this is significant in the overall schizophrenia group, as well as the AH plus group. And it's pretty, there's a moderate association even in the AH minus group. And this is quite notable because it really has implications for using this kind of paradigm in schizophrenia. We're definitely observing interesting effects in terms of the mismatch ratings, and I'll be discussing that in just a minute. But, the providing prior information, manipulating context, which is what we were doing with providing that matching or mismatching text, that has been a really useful method to try to understand predictive processing. And it looks like in our sample that we perhaps are being hindered by these working memory impairments. Of course, we also looked at the match and mismatch ratings. There were no associations between cognition and ratings on in the mismatch condition. However, lower match ratings were significantly associated with worse working memory performance across both the total schizophrenia group, but also the AH plus and AH minus groups. Okay. I'm going to switch gears now. So I noted that another aim of our work that's become increasingly clear is to better understand the phenomenology of voice hearing experiences in schizophrenia. This comes from, working with individuals who have studied these experiences for many, many years. I'm relatively new to focusing on auditory hallucinations myself, but it also comes from interacting with a lot of our subjects who describe their voice hearing experiences. In fact, I will never forget the first time a subject said, yeah, I have voices, but they're not audible. And I didn't really understand that. That was one of our very early subjects. And he explained that sometimes he literally hears the voices, but other times they're communicating with him like telepathically or transmitting messages into his brain. And a lot of our subjects have described these phenomena. In fact, I'm very involved in training individuals to assess psychotic symptoms, and now I really emphasize the importance of clarifying when subjects tell us they hear voices, are they literally hearing these voices? Or are they just using that term because they're asked about voices so much and that's the best way they can explain these experiences? And it turns out there's a whole phenomenological literature on this topic. I didn't know what the term soundless voices meant a few years ago, but now I certainly do from interacting with our research subjects. Subjects describe these experiences, passivity phenomena, also multimodal sensory experiences. Some people describe they can feel their voices, or they literally feel information being transmitted into their brains by the entities or voices that they hear. And these aren't captured at all by our standard measures. We do the SCID to diagnose schizophrenia. We use measures like the BPRS and PANS to assess symptom severity. These are based on the DSM definitions of hallucinations. And that's all about the perceptual experience. And these measures are all about frequency and severity. They don't capture any of the information about what this feels like. In fact, when we do our assessments, it's all unimodal sensory experiences. But when you ask subjects, it really is a whole body experience for some individuals. We have examined another measure with that Muzak I told you about, that measure of hallucinatory experiences. You know, one thing that attracted me to this measure is that there's a subscale that gets at these sensed presence experiences. And I will just give a shout out to Ben Alderson Day. This is an excellent book, Presence, which is all about these experiences, sensing the presence of an unseen entity or other. And he asks, are we missing something when we're assessing these hallucinatory experiences in individuals with psychosis? So we examined these measures of sensed presence in relationship to that, those ratings in our perceptual pop-out task. And remember, the higher mismatch ratings were associated with hallucinatory experiences in our AH plus group. And it turns out the associations with sensed presence were even stronger. Higher mismatch ratings on our perceptual pop-out task were associated with a greater frequency of sensed presence experiences in our total schizophrenia group and in our AH plus group. Pretty strongly associated in our AH minus group as well. You can see these are small sample sizes. That is a big limitation here. We started the Muzak, we started some of these measures a little bit into the study. So we don't have a big sample yet, but we're pretty excited about these observations. And I want to give a shout out to my research assistant, Haley, who just presented at Society for Research in Psychopathology, all about sensed presence experiences and the associations with symptoms. These experiences are related to symptoms, but very specifically positive symptoms. You know, we didn't find any associations with our BPRS measure except for sensed presence. It's strongly related on our total schizophrenia group. And there are no associations with negative symptoms, disorganized, affective, or activation symptoms as measured by the BPRS. Specific symptoms associated with sensed presence include hallucinations and suspiciousness. And that Muzak measure also shows associations, and very interestingly, these are observed in our healthy control subjects as well. Okay, so I'm going to summarize now. So our initial results suggest that the innovative EEG methods that are used to assess cortical tracking of natural stimuli, such as narrative speech, hold promise for characterizing speech processing in schizophrenia. So looking at schizophrenia-related impairments, but also potentially for investigating alterations that may play an upstream role in auditory hallucinations. That's the idea with those early auditory processing impairments. Remember, I talked about how there are hypotheses that that might actually trigger a compensatory overweighting of prior information during perception. Initial results suggest that individuals with schizophrenia who hear voices may be impaired in early encoding of speech stimuli over and above schizophrenia-related impairments. In contrast to what we expected, we did not find evidence that auditory hallucinations in schizophrenia were associated with a stronger perceptual pop-out in our degraded speech task. So when we provided them with prior knowledge, they didn't have a stronger pop-out. In fact, they had the smallest pop-out. And that did seem to be in part related to reporting more words in the mismatch condition. Interestingly, those ratings in the mismatch condition were associated with more frequent auditory and visual hallucinatory experiences and sensed presence in our AH plus participants. This is something we really have to keep in mind, and I think this has like broader implications of how we get at these questions. Our index of the effects of prior knowledge on perceived clarity of degraded speech was associated significantly with poorer verbal working memory performance. So the behavioral results with our perceptual pop-out task are really interesting. Those associations with higher ratings in the mismatch condition, those are consistent with other findings in the literature, suggesting that paradigms that tap the response to ambiguous stimuli without explicit priming may be especially sensitive to these putative alterations in predictive processing. And when we think about the Mooney face task results, the degraded speech task results, the sensed presence results, all of that seems to be hanging together in terms of this greater tendency to kind of create cohesive percepts or meaningful percepts like speech or faces when confronted with ambiguous stimuli. And as I noted, there are findings in the literature with non-clinical voice hearers and individuals at clinical high risk showing the same pattern of results. At the same time, the associations with cognitive performance suggest that manipulating context, it's a great strategy. Others have used it, but we really have to keep in mind there might be some limitations because of the cognitive impairments associated with schizophrenia. We have trend level associations and also some significant associations at our healthy control group, suggesting that the ratings on the mismatch condition may be sensitive to these putative predictive processing alterations associated with hallucinatory experiences, even in non-clinical samples. I can't see that. 2 minutes? Okay. Oh, sorry. I just want to go through this really fast. There are major limitations. We have small sample sizes with our subgroups, right? We're doing quite well overall, but when we break it up into AH plus and AH minus, especially with some of those later measures we introduced, like the MUSAC, our numbers are quite small. We're so excited about this line of work, so we're keeping going with data collection. Another big limitation is that we don't have a method, at least with the perceptual pop-out task as currently designed, to really assess how what individuals are perceiving. It's been discussed a lot in the literature that some of these responses may reflect a positive response bias, a tendency to say, yes, I'm hearing something, I'm seeing something. It also could reflect illusions, right? So when subjects are reporting words in the mismatch condition, it might reflect auditory illusions. We really don't have a way yet with that paradigm of determining exactly what they're hearing. Heterogeneity is a huge issue in our field in schizophrenia research. In our sample, definitely a mix of folks on antipsychotic medication, off antipsychotic medication, and we collect information on responsivity to treatment. So how are your symptoms responding to treatment? There's a mix, it's across the board. Some of our subjects report wonderful effects as a result of antipsychotic medications. Others, their symptoms don't seem to be affected. And we're lumping all of these folks together, and that's certainly hindering our ability to address these questions. So that's under questions. How do we tackle heterogeneity? Also, how do we think about incorporating these multimodal experiences and these other like passivity phenomena when investigating these mechanisms of psychosis? Our next steps are to incorporate EEG to examine acoustic and phonetic feature encoding in our perceptual pop-out task. We also have some other measures of early auditory processing. I didn't present today, but we will be incorporating that as we go forward. I just want to say thank you very much.
We have some really good questions coming. Do you have any questions here in the audience? Oh, okay, Julie.
It's not on. Okay. Oh, yeah, I guess it is. Hi, Judy. That was really such a nice talk. It was really great to catch up on things. One thing I was really struck with early on, before you said all this other interesting stuff, was the idea of the verbal working memory, perhaps confounding a little bit your mismatch task, right? Because when you played it and we all did it and everything, some of us that don't have great verbal working memory to start with, which, as we all know, like lives in our dorsolateral prefrontal cortex, right? You kind of got to remember what the words were before you go hear it again, right? And I was just wondering if you would consider the words always precede the mismatch or not? I mean, or do you just put it up simultaneously so you can refer to it?
There have been some studies using that method of actually displaying the words or the sentences on the screen as subjects are listening to the stimuli. And I think that could be kind of a method we consider. Yeah. And also, we are very interested in examining kind of the stable priors or stable tendency to perceive meaningful stimuli. So that is what we think we're getting at with the mismatch ratings. So another strategy that we thought of is not even using priming. So as I noted, there is some literature suggesting alterations in young people at clinical high risk and also non-clinical voice hearers, showing a tendency to report more words in degraded speech, even when they're not primed.
Okay, now we'll take a question from over Zoom. You described thoughts being placed without voices. How does this differ from what Kurt Schneider described during the 1950s as thought insertion, which he included among the so-called first-rank symptoms?
Yes. I think it could be considered thought insertion, but as you know, when I train folks on assessing schizophrenia, assessing psychotic symptoms, we talk about the definition of hallucinations and delusions. Thought insertion is considered a delusion, right? I believe that thoughts are being inserted into my mind or into my brain. The thing about delusions, though, is that we think of them as persistent beliefs. When subjects describe these phenomena, it's more discrete or punctuated, almost like hearing a voice, right? So that's a big difference between voices or hallucinations and delusions, kind of that persistent aspect. Is it ongoing? Yeah, I'm still convinced of that. I've been convinced of that for years, versus having these individual experiences of hallucinations. And what I've learned is that inserted thoughts, we use that term. Yes, it's a delusion and people are convinced of that, but people describe it as an experience and not a voice, or I'm sorry, not a belief, right? So I think that those experiences can reflect or end up resulting in these persistent beliefs. But there's also something else that I do think we're missing in terms of these more discrete experiences.
So you mentioned these things can be whole body experiences. So like if someone's seeing light, they might also, from the sun, they might also feel heat, for example, on their skin. And actually, when there's sensory experiences, there are effects throughout the body. So one issue could be that when there's a sense presence, sometimes people hear a voice, sometimes they just sense something, another person's there, right?
Yeah.
But maybe they don't actually hear anything. And so that's another way I think it's different than just a delusional belief. There still is a sensation of something, and even if they can't hear a voice, they might sense that somebody's there thinking about them, somehow communicate.
Yeah. So just really quickly on that point about sensed presence, I don't think I mentioned that we're finding significant group differences between our schizophrenia participants and our controls. As expected, sense presence experiences are associated with psychosis. They're also associated with all sorts of other experiences, neurological conditions like Parkinson's, for example, also extreme sports, solo sports, survival experiences. People report kind of this almost like sensing something there. A big limitation of the MUSAC, of our assessment of sense presence, is that we don't collect any information. We haven't collected any information on the link with voice hearing experiences. But I will say anecdotally, like when you're assessing individuals about their voices, there's like a common language emerges, really. Like there are entities or agents or alters in me, right, that I'm hearing, they're communicating with me. And so it would be amazing, I think, to really get at, is that what the entity is that they're sensing? How is it related? And there's really not that much research on sense presence in psychotic disorders.
Okay. Well, I think we have time for one more question. This one, great presentation, Judy. I'm curious about sense presence symptoms and potential overlap with symptoms from trauma-related disorders, including dissociative disorders. Yeah. Many patients with these disorders are misdiagnosed with psychosis due to experiences of, quote, hearing voices, unquote, that are really accounted for by structural dissociation that patients don't know how to describe. Do you also assess for dissociative symptoms in your studies, and how do you see similar findings among individuals with dissociation proneness, if not?
Yes, there is an association between sensed presence and dissociative experiences. There's some research on that, and Ben Alderson-Day talks about that link in his book. We don't assess formally dissociative experiences, but anecdotally, I will say that when people are describing hallucinatory experiences, sense presence experiences, it sometimes has that flavor. And you may know dissociation is very related to past trauma experiences and PTSD. And traumatic experiences are linked to an increased risk for psychotic disorders. There's a strong association between PTSD, trauma, and psychosis. So sometimes we're struggling, even when we're assessing subjects, to really understand, is this a voice or more like a flashback of their abuser? And then they're like sometimes describing what seems to be these like bodily dissociative experiences. So we're not formally assessing that. I think it's a great observation in terms of those links.
Okay, we have a few seconds left, and I'm going to take the liberty of making the last comment. So one of your findings was the hallucination group had a smaller pop-out effect in the mismatch to match task. And you said that kind of went against the hypothesis because you expected the hallucinating group to kind of have stronger priors, that hallucination. But to me, it kind of fits the hypothesis because the whole point is that the hallucinating group isn't using the priors that are in the real world.
Yeah.
They're using their own internal priors. And I think really what has to be gotten at with this is how much are people using their kind of emotion, fear, or whatever, isolation, based emotional priors rather than priors that the experimenter introduces, which may or may not have meaning for the person.
Yeah.
So that's just something to think about going forward, I think.
I think that's a great observation. I mean, it fits with the pattern of findings that people with hallucinations are often impaired on processing what's actually there, but seem to be like kind of have an augmented tendency to detect something there when it's not.
All right, everybody. Well, this was really interesting. Thank you for coming, and have a good day. And actually, we won't have another Engel rounds, believe it or not, till 2026 because the Engel rounds falls on always Thanksgiving week and Christmas week. But please come to all the other grand rounds, which start next week.